Good evening. This is Josh Goodwin, doctor here at Regenexx Las Vegas. I'll be giving the webinar and we're going to talk about osteoarthritis. Shouldn't be a long presentation. Just really want to walk through some of the basics, including what it is, prevalence, treatment options, and just hopefully help people understand what it is and what they can do about it. As I said, my name's Josh Goodwin. I'm the doctor here at Regenexx Las Vegas. We like to have these webinars to allow people to log on and maybe learn some information about different treatment options for orthopedic conditions, which is mainly what we focus on. We do talk about different topics, about very specific joint conditions like knee arthritis or shoulder issues or spine, different treatment options. Today, we're always going to talk just briefly about what is osteoarthritis. At the end, we do have a question and answer. So, outside of what I cover in the presentation, it allows a little time for people to have some questions that I can try to answer. It is okay to type those down as you think of them within the chat or the Q&A sections, just so they're there. And then once we get to the end, I will cover all the questions, okay? So we'll just jump into it. Just a little bit more about my background. So I am a medical doctor. I grew up in New Mexico, and that's where I stayed for medical school at UNM. I did my residency training in physical medicine and rehabilitation, which is a non-surgical field. But we deal a lot with orthopedic problems, amongst other things that might impact your function or cause pain or just functional status. I did my fellowship training in sports medicine and interventional spine. At the time, the clinic I was at did do some regenerative medicine with PRP and stem cell-based treatment, which is where I got exposed to it. I am board certified. I've been with Regenexx, which is the clinic I'm with now, since 2015. And I've co-authored some articles on using, reviewing treatment options for low back pain and disc degeneration with stem cell therapies. Just a brief word about Regenexx and really what Regenexx is. It's a large network of physicians throughout the world. We have clinics in the United States and some international clinics. It's been around since 2005 with the main goal of advancing non-surgical orthopedic care. So trying to find ways to prevent that progression for the need of surgical intervention and try to help people maintain and retain their tissues. We do publish a lot of research as an organization. We have the largest and oldest outcome registry for patients we treat. There's more than 100,000 patients in the registry. We do have some cellular processing patents for orthobiologics, which we briefly mentioned. Again, this isn't a webinar to talk deeply about all the different options, but more of an overview. And really our main goal is just advancing non-surgical orthopedic care, what I like to call orthopedic wellness, so that people can stay functional and not have to undergo surgical intervention when possible. So as I said, some of the objectives today, again, we're just talking about osteoarthritis very specifically. So we'll define and look at the prevalence, discuss affected joints, causes, risk factors, symptoms, diagnosis, treatment, briefly introduce the idea of orthobiologics, since that's what we focus on as far as treating joint issues, including osteoarthritis. And then we have the time at the end for question and answer. So what is osteoarthritis? I think some people think, I'm not really sure what all patients think, but it's not typically something you can just take out or remove. It's really referring to a degenerative joint process that is characterized by kind of over time progressively breaking down of your cartilage. Your cartilage is a cushion that lives between two bones that form a joint. and it helps provide cushion and support, shock absorption, lubrication, those kind of things. So the progressive breakdown of cartilage is part of the osteoarthritic degenerative process. There's also a chemical imbalance inside the joint between what we would call anabolic, anti-inflammatory factors and proteins and enzymes, and catabolic, which means breakdown, inflammatory pain-producing chemicals. When that balance gets disrupted, you will see more breakdown of the joint. And so that's part of this process. So it's not just a structural, but it's a chemical process. The joint spacing between where the two bones come together start to narrow because of the narrowing and thinning of your cartilage. That leads to bony remodeling, which is where we start to get bone changes because of stressed and overloaded bone from the lack of cushion, which can lead to bone spur formation, little microfractures in the bone that can become painful. And all of this can start to lead to thickening of joint tissues, inflammation of your joint lining, which can be what creates pain. This over time can lead to some tightening of the joint capsule, lack of motion, weakening of surrounding tissues, instability, all that stuff. So as you can see on the screen, it affects lots of people worldwide, 500 million worldwide, 32.5 million in the US. Over 10 to 13% of people have it over 60. So you're going to know someone with some osteoarthritis at some point. Women have a little higher incidence. Obesity and being overweight does impact your risk, doubling and tripling the risk for joint stress and osteoarthritis. And then it just costs a lot of money to deal with these issues, whether it be time out of work, medications, injections, surgery, recovery, all those things. It's very, very expensive. And as we continue to age as a population, the prevalence of surgeries and intervention and osteoarthritis is just going to increase. I did mention that kind of the initial stages of osteoarthritis is the wear and tear of the cartilage, which has lots of influence as to why that might happen, which we'll get into a little bit, but traumas, genetics, chronic inflammation, obesity, all those things, diet can play some roles. But cartilage is the shock absorber on the end of the bone. And so it's a connective tissue that's made up of collagen, and it kind of helps protect the underlying bone. It has no blood supply, which is why it's hard for it to heal. But it also has no nerve innervation, which is kind of some people wouldn't expect, because why does arthritis become painful? The cartilage itself has no nerve innervation, so directly it's not a cause of pain, since there's nothing to emit pain from within the cartilage. But it's a lot of the surrounding tissues, like the underlying bone, which does have nerve and blood vessel innervation, and your joint lining, which also has nerve innervation, which can emit pain, where pain chemicals and inflammatory chemicals combine and create the awareness of pain coming from that joint. Your cartilage is mainly water. It is made up of a matrix, extracellular matrix that gets kind of pumped out by your cartilage cells, which are called chondrocytes. So that's pretty much what it is. Water, some proteins, and cartilage cells. And we were saying that how a cartilage is maintained, it doesn't have blood supply. So how does it live and maintain? It's through the underlying bone called the subchondral bone. that can feed and help maintain the cartilage. And so if this connection gets injured from impact, trauma, shear stresses, then that can injure the underlying bone, which can thicken and scar, enlarge, thereby injuring the cartilage, and that can create a progressive degradation of that tissue. Your joint fluid, called synovial tissue, and the compressive forces of walking and load can help keep and feed that cartilage. Having a well-balanced chemical environment helps maintain your cartilage. Good, strong supporting muscles, ligaments can also help as well. So just an example of if you have what we call osteoarthritis and a orthopedic surgeon puts a camera inside your knee, over on the right-hand side, this would be a normal looking cartilage surface, which is very smooth, as opposed to the picture on the left, which has exposed bone, which they point out with the arrows. There's some fraying and kind of roughening up of that cartilage tissue. And so that's what that is. This is what osteoarthritis would look like within a joint, at least one component of it. This is the cartilage structural component. You could see changes inside the bone, and chemically you can, if you were able to assess that, you could see changes there as well. And as I was mentioning, it's not just a structural problem from cartilage destruction, which can lead to bone remodeling. And then some of that pain and inflammation of the joint can create a signal where muscles are inhibited and weakened, which further destabilizes the joint. But it's also a constellation of inflammatory proteins and enzymes that lead to the further destruction of the joint and pain. So it's a combination of chemical and structural changes that work together to then create pain, dysfunction, and the progressive changes that we can see with osteoarthritis. If we're looking at the most affected joints, really hips and knees are probably the more common. Spine issues are very common, hands, but it can affect any joint in your body. We've seen people with jaw arthritis, neck, finger, hand, toes, those kind of things. So it can affect any joint. These are just x-rays where we're seeing the lack of joint space between the two bones that form the joint, whether it be the knee, the hip joint, the shoulder joint. We've alluded to this a little bit already as far as the causes and risk factors for the development of osteoarthritis. There's not just one thing that plays a role. It's kind of multifactorial. So age, we said, as we age, the incidence goes up. Joint injuries can increase the onset or the progression of osteoarthritis. So having an injury directly to the joint can accelerate that. This can include surgical intervention. So if, for example, you have a meniscus tear in your knee and you get surgery to remove the meniscus, the injury itself and the surgical intervention can accelerate the development of osteoarthritis. Overuse, which again is just going to be more impact and maybe more trauma. Obesity, as we said, increases the risk of osteoarthritis, likely through loading, but also systemic inflammatory changes. If for whatever reason we have malalignment from congenital alignment of our bones are slightly off, or from overcompensation, injuries, those kind of things. If we have weak muscles that don't support the joint, either because of other problems where you've injured a muscle or you have a pinched nerve that doesn't allow that muscle to function, that can lead to development of osteoarthritis through lack of control and support. Genetics, it can run in the families. And so despite doing everything well, no injuries, good weight, good strength, good flexibility, you can still get osteoarthritis just because of your parents. We talked about gender and then environmental factors. Again, strength, hormones, bone density, diet, obesity, these kind of things can play a role as well. The symptoms, if are usually pain is what brings people into the clinic. It's common to have joint stiffness, specifically after periods of inactivity, like sitting or first thing in the morning, that improves as you get going. Range of motion can become limited. You can get swelling and inflammation. The joint feels weaker than it used to. It might give way or buckle. For hip osteoarthritis, people tend to have pain in the groin area, but it can sometimes be in the buttock region, and it can radiate all the way down to the knee sometimes. For knees, depending on which portion of the knee you have osteoarthritis, inside, outside, or throughout the whole thing, you might have more focal pain. There can be cracking, popping, grinding, those kind of things. Fingers, you might see bone enlargement and stiffness. Same thing with the foot as well. Usually it's diagnosed by talking to the patient. Usually imaging is a big part of the evaluation. You can, on occasion, do lab tests if you're trying to rule out other causes of joint pain like gout or other autoimmune arthritic conditions like rheumatoid arthritis. But imaging with x-rays and MRIs are very helpful. This picture is an MRI of a knee showing what we can see structurally when someone has osteoarthritis. So there's lack of cartilage between the bones. The meniscus is worn down. There's thickening of tissues around it, like the joint lining. And we have swelling in the underlying bone called subchondral edema or bone marrow edema. There's a little collapse of the inside joint space compared to the outside. So these are things that we would say this person has bone on bone of the inside or the medial compartment of the joint. When you're looking at it, you can grade arthritis. There's different grading classification scales, but this is one used often where grade 0 or 1 is no evidence or minimal evidence of change, to grade 4 being kind of bone on bone, large bone spurs, what we call sclerosis and bone deformity. So this is kind of what we would call the worst state or worst grade based on imaging findings. Now, treatment options, there's lots of things. A lot of it, it's always good to start with non-surgical treatment and to do this as early as you can in the process of osteoarthritic symptom development. Everybody should do lifestyle modifications. If you're overweight, lose weight, change diet, reduce inflammation, modify activity to more low impact exercise, but still stay active and functional, improve strength and mobility and stretching to the best of your ability. Physical therapy and some guidance on how to improve biomechanics. Why are you getting only right knee arthritis and not left? What can be done to optimize symmetry and strength, and that can be helpful. Temporarily, medications can be used to improve symptoms like Tylenol or ibuprofen, topical treatments, and even supplements like turmeric, glucosamine, collagen. There's some data to show that that may help for some patients. We're going to talk more in a second about chronic ibuprofen use and how that may actually be counterproductive for improving your arthritic joint symptoms. There are injection-based treatments that are have been used more commonly, like steroid injections and gel injections. We'll talk a little bit more about corticosteroid injections and some of the downsides to those. Some of the things that we focus on here to treat osteoarthritic joints is orthobiologic treatments, such as PRP, which is where we take your own blood and extract the platelets, which can help promote and help strengthen cartilage and preservation and really have a good positive effect on that chemical environment to reduce those catabolic inflammatory signals and chemicals within the joint that further create destruction. Stem cells and bone marrow concentrate can be helpful. Prolotherapy is kind of a dextrose solution that can help kind of more milder situations or help strengthen tissues around arthritic joints. And of course, surgery is an option as well. You want it to be the end of the line because once you do get a joint replacement, it's hard to go backwards from there. You can't really. So if you still have pain after a joint replacement, it becomes a little more tricky to figure out how to get the joint feeling better. I just wanted to briefly touch on chronic non-steroidal anti-inflammatory use and repetitive steroid injections. So there's growing data to show that using ibuprofen chronically or that class of medications on top of the black box warnings for stomach ulcers and increased risk of stroke and heart attack, kidney dysfunction and injury, long-term use is associated with more arthritic pain and accelerated progression to joint replacement. So something to consider if people are taking that on a long-term basis. So it's good to find alternatives, whether it be joint supplements, more injection-based therapy like orthobiologics that are a little healthier, lose weight, change diet, improve strength, modify activity. Those are going to serve you better over the long term than trying to rely on ibuprofen. Steroid injections, while they can be helpful and they are used, they're overused, we think now, they do help improve inflammation, but they come at a cost. So repeat steroid injections causes accelerated arthritis. They can lead to insufficiency fractures of the bone by weakening the tissue, bone death, and a quicker path to the surgical table for joint replacement. So they're used a lot, but they can come with some costs in the long run for your joint health. Joint replacement, most people have heard about. It's essentially an amputation of your joint to cut off the pieces of the bone that are affected where the cartilage is gone and replaced with a metal surface. Ideally, it's used as the last line option and you failed all other options. Because once you get a joint replacement, like in these pictures, you can't go back and reverse that, right? And so if you're one of the people that still has dysfunction or complication, it becomes more tricky to figure out what to do with it outside more surgery. The number of joint replacements is increasing as we age and as more and more people are going to develop osteoarthritis. More and more people are obese. And so the combination of aging, poor health, obesity, is going to increase the rate and the prevalence of osteoarthritis and joint replacements. And these are not without significant risk. So it's just good to be aware of all options and tools, but also understand the positive and negative sides to it. So joint replacement risks, persistent pain, up to 20% of people still have pain after a joint replacement. So 1 in 5 patients will still have pretty significant pain. Infection in up to 2%, blood clots, hardware failure where you have to go back and revise and replace the hardware. Dislocations can happen in hips and shoulders, nerve injury. Stiffness can happen up to 15% of the time. A lot of times in knee are replacements. Allergy to the metals, fractures around where they're trying to put the metal into the bone, Revisions can happen within the first 10 years for up to 10% of people. And because it's such a stressful thing on the body, there is a significant increase of heart attack after the surgery within those first couple weeks and maybe in those first few months. So it's not without significant risk that some of these things are not always talked about. Sometimes it's the right choice, but if we can learn how to intervene earlier, then with other things to help improve the tissue directly, that can be helpful. Orthobiologics, some of the things we focus on, these are natural healing factors that can be derived even from your own body. And then these can be delivered to these areas of degeneration to improve the tissue, rebalance that chemical environment. And these are just injection-based procedures that can be helpful and minimally invasive. So basically, these are substances that can help promote healing. They can be injected, and oftentimes for certain surgical interventions added to improve outcome. And they can directly strengthen tissue, improve blood supply, reduce inflammation, improve the chemical microenvironment, which can then lead to preservation of your orthopedic tissue. So that's kind of the goal with that. There are different types and categories of orthobiologics, from growth factors, PRP, which is platelets from your blood, different types of stem cell therapies, extracellular matrix to create a network for cells to grow in. These are out there. Just a brief summary. We're not going to go into big detail with these, but again, other webinars are more specific on this that have been posted in the past. But PRP contains growth factors, which can help increase healing and kickstart your body's healing response. Cytokines are chemical messengers that can help as anti-inflammatory factors and protection of cartilage. The scaffolding, the extracellular matrix, can help with cells growth. And then stem cells can assist with repair by either becoming that tissue or helping orchestrate a healing response. So they can be used to help target osteoarthritic joints, better to target them earlier as opposed to later in the overall cascade of osteoarthritis. These different orthobiologics have been studied extensively in different joints. This is more specifically looking at PRP for knee arthritis, hip arthritis, shoulder arthritis, lumbar, so back arthritis, ankle arthritis, showing benefit compared to other things that are traditionally done like gel, steroid, surgical intervention, saline, those kind of things. So other studies looking at arthritic treatment with PRP, as we talked about, and stem cells. Lots of studies looking at them as treatment options to help improve outcome. So that's kind of the brief kind of overview of osteoarthritis, what it is, prevalence, risk factors, treatment options. We just want to get into some of the questions. So if anybody has questions, they can write that down. I will put up the next slide, which is just contact information. As I mentioned, we do treat non-surgically orthopedic conditions to include osteoarthritis with different orthobiologic injection-based treatment. Not everybody is a candidate for those types of treatments. So if you did have some osteoarthritis and you were wanting to look at different options besides your traditional path, we do consultations to see if you're a candidate and what type of candidate. Is this a good option or not so good option for you? Because everybody's situation is a little different. Are you mild or severe? What else is going on that could influence the joint? Danielle can help you get set up with a consultation. Her email and phone number is there. We have a patient education center that can give you some basic information to see if coming to see us is something you want to do. Let me see if anybody has any questions. If there's no major questions, then just jot down this information. And if anything comes up in the future, you can reach out to us and we can help answer those questions. or come see us and we can do a full evaluation so you can understand all your options. Doesn't look like anybody has too many questions. We try to do these webinars once a month at least. Try to do different topics, either more specifically about different orthobiologic interventions or different joints, for specifically just talking about knees or shoulders or spine. Learning more directly about PRP or other orthobiologic treatment. You can look out for those as well. We continue to do these as a way to just educate people and allow people to learn more about different tools for orthopedic intervention. So I appreciate you guys logging on and listening to me talk for a little bit. Yeah, thank you. We'll see you at an appointment. So give us a call. We're here, we're more for education, let people know what all their options are. So I'll let you guys get back to your evening. Again, I appreciate your time.